to our newest CUPID Scientific CUPID webinar. Respected colleagues, ladies, gentlemen, welcome to this webinar entitled Towards Equity and Healthcare Updates from the CUPID Cost Action. Today, we gather as researchers, clinicians, policymakers, and advocates to explore how we can advance equity in healthcare for individuals with intellectual disabilities. Over the past and half years, the CUPID network has been dedicated to identifying and addressing key disparities in cancer prevention, diagnosis, and treatment with intellectual disability community. As we approach new milestones, we reflect on impactful research, collaborative efforts, and policy recommendations that are shaping a more inclusive healthcare system. Health equity remains a fundamental priority. A growing body of evidence shows that individuals with intellectual disabilities face significant challenges in accessing timely and adequate health care. The underdiagnosis of cancer, lower survival rates, and systemic barriers in medical systems highlight the urgent need for tailored interventions, and today's webinar will provide crucial updates on CUPID's ongoing work, reinforcing our commitment to ensuring that no individual is left behind. Our objectives remain clear: strengthening research collaborations across Europe and beyond, enhancing knowledge sharing on best practices in cancer prevention and care, encouraging interdisciplinary approaches to improve healthcare accessibility for individuals with intellectual disabilities. Throughout this webinar, we will hear from young research experts on topics such as recent findings on cancer prevalence in individuals with intellectual disabilities, strategies for improving screening uptake, policy recommendations for equitable healthcare access, and let's make this a meaningful and productive discussion. Each presentation will last approximately 8 to 10 minutes, followed by a discussion session at the end where we welcome your questions and comments. Also about housekeeping, a few words. Please turn your audio, your microphones, and also it will be good if only the speaker show with the camera when he or she is presenting. Now I'm inviting our first speaker, Amina Banda, to take the floor with their presentation, Cancer Screening Participation Among People with Intellectual Disability in the Netherlands. So also I want to mention that this webinar is recording, and if I get the link from the organizers from CITU, I would like now to thank Françoise and Florian for their background support. The link will be uploaded on the CUPID YouTube video channel, and also the print screens and pictures will be taken. And if you don't want to appear on the social media, please turn off your camera. Okay, now let's start. Amina, please start with your presentation.
Yes, thank you, Vladimir. So hi everybody, I'm Amina Banda. I'm a PhD candidate at the Radboud University Medical Center in Nijmegen, the Netherlands. And my PhD project focuses on the cancer screening in people with an intellectual disability. And today I will be describing a project of mine, which was the cancer screening participation and outcomes among people with an ID in the Dutch population. So first on content, I will give some background information, give you some, tell you something about the study design, the results, and following the conclusion and next steps within the project. So why why do we do cancer screening? Cancer screening improves early detection of cancer, improves cancer treatment possibilities, and also improves survival rates. By the aim of the national screening programs is to detect the common cancers before symptoms appear, and thereby minimizing the impact of the disease on the individual, but also on society. And we have currently 3 screening programs within the Netherlands, one for cervical cancer, one for breast cancer, and one for colorectal cancer. How does this look? For cervical cancer, people are since recently get a self-test kit at home where they're tested for HPV, and then following a pap smear is performed if HPV is present. Is targeted for women between the age of 30 to 65, and the frequency is every 5 to 10 years, depending on the screening outcomes of the previous year or the age of the individual. Breast cancer, it's done to a mammography for women between the age of 50 to 75, and frequency is every 2 years. And colon cancer screening is for both men and women. They are invited, they receive home test kit, which is called the fecal-occult blood test. And in case of an unfavorable outcome, meaning that there's blood tested within the stool, colonoscopy is needed, and frequency is every 2 years. So if you go back to the ID population, one question remains, and it's actually what is currently known about the participation in cancer screening among people with an ID in the Netherlands. Do they participate in similar rates? What are the screening outcomes, etc., etc.? So then we go to the study design. We have 2 main objectives. It's to compare the participation rate and screening outcomes between people with and without ID. In addition to that, we want to evaluate the screening outcomes between the ID population in comparison to the general population. And the screening outcomes are, for example, the mammography, if somebody is tested with a high BI-RADS score and a possibility of cancer. So to answer this question, we have access to a quite large database from 3 different screening programs from a time frame from 2015 to 2021. We have identified approximately 180,000 people with ID. People with ID are identified through people with ID are identified and selected through healthcare and welfare databases. This has been described in detail in another paper, so if you're interested, you can look that up. And then we have selected a bit more than 760,000 people from the general population from a 1:4 ratio in comparison to the ID population. And now to the more interesting part. So the results of our study, the outcomes are pretty clear. People with ID participate significantly less in comparison to the general population. It's significantly less for all 3 programs, and the participation rate is actually 20% lower for each program in comparison to the general population. And participation is the lowest for cervical cancer screening. However, they're very similar in participation rate. Then when we look at the screening outcomes, unfavorable results, meaning that cancer is possibly visible and possible in people with ID, in a person, sorry, it occurs just as often in people with and without ID. And there are actually more invalid results in people with ID in comparison to the general population. Invalid results is actually quite a broad term. It means wrong sampling, insufficient sampling, etc., all those cases. And when we focus on the colon cancer screening, we see that the follow-up procedure are less likely to participate in ID population, so the colonoscopy, for example. So we can conclude that people with intellectual disability have a lower participation rate for cancer screening programs, but their outcomes are actually comparable, even though they participate less. and invalid screening outcomes are more common within the ID population. It highlights the importance of improving accessibility, and it also emphasizes the need for adapting screening programs to better reach this group. There are some limitations that we need to mention. There's no national registry in the Netherlands for identification with ID. So we have identified them through the access of healthcare and welfare basis, but this lacks details on severity or the ID etiology. So, for example, if they have the syndrome, Down syndrome, and we also possibly miss a high group of people with low intellectual disability. So we need to keep that in mind. It might be interesting to also mention that for the next step within my PhD project, we want to explore the experiences, attitudes, and barriers related to cancer screening from both the perspectives of the healthcare professionals and the people with ID. For the healthcare professionals, we want to do this through a participatory research approach where people with the healthcare professionals will identify key barriers, but also discuss with each other how the system works and explore potential intervention points so that we can understand the underlying context of the barriers and not only mention them. And for the interviews with people with ID, we want to understand the reasoning for participating, but also for non-participating in the screening programs. And by that, and following to discuss acceptable and most and appropriate ways to facilitate participation for this group. And then the final goal of the project, or the final aim of the PhD project, is to identify the first steps to improve the national screening programs and to increase accessibility for people with ID. And it was really briefly something about my project. So thank you for your attention. If there are any questions, I would like to hear them.
Oh, thank you very much, Amina, for your very briefly presentation and insightful as well. You highlighted a critical area of public health that is often overlooked, and your findings offer valuable perspectives on how we can make cancer screening more inclusive for people with intellectual disabilities. And also, we appreciate your thoughtful research and the clarity with which you presented it. The questions will be at the end, as I mentioned, and now we are going, and I'm going to invite Anna de Wit. She will present Exergames to enhance physical activity for children attending special needs education. Physical activity plays a vital role in overall well-being, and innovative approaches like exergaming offer new opportunities to engage children in meaningful movement-based activities. So the floor is yours, Anna, please.
Yes, thank you. My name is Anna de Wit. I'm a physiotherapist and a movement scientist, and currently I'm a PhD student at the Radboud UMC as well as Amina. So my research is about how we use Exergames in special needs education. My research is a collaboration between the St. Maartens Clinic and the academic association Stronger on Your Own Feet. Yeah, so if we think back to our youth, we can all imagine how we got to school. For example, we biked to school in the Netherlands, or we walked to school. And after school, we often have had a lot of opportunities for outdoor play or at the local sports club. But as you can imagine, for children with disabilities, and especially children who attend special needs education, this is a little bit different. They get picked up in the morning by a bus, so they don't have active transport to school. And during the day, there are also less opportunities for physical activity. Not every sports club offers inclusive play or sports teams for children with disabilities. And there we talk about children with intellectual but also physical disabilities. But as we know, gaming is very popular among children and youth, and we can think this can be an opportunity to enhance physical activity for children with disabilities. So in my research, we want to see if we can use Exergaming, and there you can think about Nintendo Switch, where you can play Wii Tennis or that kind of stuff, or Pokemon Go. How we can use those existing games for children in special needs education. So we wanted to see what the barriers and the facilitators are affecting the play of Exergames in children attending special needs education. We did focus groups with children, parents of children with disabilities, and also professionals working with the group. We asked them about their experience with Exergames. What are the challenges and the possibilities associated with playing Exergames, and what is the supervision needed for this group? The last question we only asked to parents and professionals. Data was analyzed using the COM-B model, which is a model for behavioral change. And we did the analysis trying to use the capability of the children, opportunities children have, and motivation. This is a model by Michi. After the analysis of the data of the focus groups of our participants, 4 teams emerged. First team is matching Exergames to children's capacity is challenging. Matching the Exergames is challenging because there are a lot of different children in special needs education who have a lot of different capabilities. For example, some people are capable to hold controllers to play games, others are not, and not all children can handle the same kind of stimuli. One parent told us, because there are so many games, but also so many different abilities, different talents, and also lots of different challenges they face. That is a thing they struggle with. Also, the characteristics of Exergames can be, some people are very good at different Exergames with different languages, but that's not always the game. A parent told us English games, that's a bit tricky because he doesn't speak English. I had both a Pokemon Go game for his little brother, actually, but it turned out to be completely in English. I hadn't noticed, but they don't play it because it's just too hard. So that's the first theme of our data. The second theme is the importance of the social environment. There is a need for knowledge and effort of the social environment because children, and especially children with disabilities, are dependent of their environment. So if their environment thinks it's important, they're more likely to facilitate Exergame play. So it's important that the social environment knows which Exergames are there and which they can use, and how they can use it, and their attitudes towards Exergames. For example, often heard expression is, yeah, the only real barrier might be that parents have to spend more time to make it work. You often hear people say it's just easier to put them in front of a screen because then I get a moment of peace too. And with Exergames, it's often a little bit more, you have to put a little bit more effort into the play. For example, if you put on a VR glasses, you have to be around so they don't hurt themselves with furniture in the way. They also had some concerns about being online, and they can meet other people, and that's not always what they want. And they've sometimes expressed concerns about the people becoming reliant on technology for physical activity. They said it shouldn't replace the good things, and if it becomes too good or too fun, then there's a chance that it might happen. Yeah, that's definitely a downside to it. The third theme is the practical factors that influence the accessibility of Exergames. Exergames, and especially the devices, are not the cheapest things to have for schools or for parents at home. One parent said about using Exergames at school, yeah, they're probably not the cheapest. So then it's kind of like you can probably get one or two, but then the money is gone. But you really need like 5 or 6 of them next to each other. That probably won't be possible. They also concerned, they said some things about the safe and spacious setting that is needed for playing Exergames. You need enough space, and that can, for example, be at school or at playgrounds. But other Exergames like Pokemon Go, they need you need to be outdoors, and not all children are safe in traffic. You can't just let the children go. They don't come back always. They don't are safe in crossing the street. So that's also a thing to keep in mind. And then the third is more about the motivation of children to play Exergames. In their free time, there are also a lot of normal games they like to play. A lot of children are playing popular games, which they can also play with their friends online who live far away. So Exergames should have enjoyable elements, which are also connected to their experience they have. And the social aspects of playing Exergames are very important. It's often expressed that children like to play with children of their school, but it's not, they don't always live close by. So they wished for Exergames where they can chat with their friends online and playing Exergames together. So that's a wish for the future. So what we learn about this research, that we can promote physical activity and encourage social interactions with friends after school. Many children and caregivers want opportunities to play together, and this can be a point for the gaming industry to consider when developing Exergames for this group. Also, parents and professionals need better information about the benefits of Exergames, so they are more willing to facilitate them. And parents and professionals should develop stronger skills to effectively use Exergames with this group of children, so they can use it in school or at home, and they're not afraid to use all the devices. So this was my small presentation about the first results. If you have questions, I'd like to hear them in the end.
Yes, thank you, Anna, for that engaging presentation. Your work sheds light on an innovative approach to promoting physical activity among children in special needs education. The use of Exergames clearly holds great promise, and your findings offer inspiring insights into how we can make physical activity more accessible and enjoyable for all learners. Now, our third presenter, Monika Chełchowska, will discuss communication barriers in cancer prevention for individuals with intellectual disabilities. Effective communication is key to ensuring equitable healthcare accesses, and this presentation will highlight challenges and solutions in bridging gaps between patients and healthcare providers. So, Monika, please start with your presentation.
Good morning, everyone. My name is Monika Chełchowska. I'm from Poland, from University Warmia and Mazur in Olsztyn, and I would like to present my presentation, Communication Barriers in Cancer Prevention for Individuals with Intellectual Disabilities.
Sorry for interrupting you. Can you turn on your camera, or you don't like it that? Now it's okay. Now it's okay. Thank you.
Okay. Communication is a fundamental condition for social participation, access to medical services and prevention in the case of people with intellectual disabilities. The scale of difficulties in communication is very high. According to a study by Dwyer et al., conducted a sample of over 600 adults with ID, as many as about 58% of respondents reported communication difficulties, of which about 24% experienced them to serve degree. Only 75 of the respondents were able to communicate effectively variable. Furthermore, more than half had trouble conducting conversation with strangers or professionals such as doctors or officials. People with intellectual disabilities face numerous individual barriers that significantly hinder effective communication and consequently their access to preventive care, including cancer screening programs. The level of intellectual functioning might moderate severe, determines how well a person understands abstract concepts such as prevention, cancer, or examination. The study by Dwyer et al. Found that a higher level of disability, the presence of comorbid conditions such as Down syndrome, for example, and limited social activity are associated with low verbal and nonverbal communication skills. At the same time, a strong link was observed between communication difficulties and changes in behavior, which may be a response to frustration arising from misunderstanding the diagnosis procedure. People with ID often cannot give informed consent for examination because they do not understand their purpose and the procedure, resulting in their exclusion from such programs. Communication channels are inadequately adapted, preventing coordinated asking questions and clarification in an understandable form, for example, through easy-read materials, pictograms, or visual aids. In the context of healthcare, people with intellectual disabilities face numerous environmental changes that hinder effective communication. In a study by Cashin et al., a survey conducted among 279 nurses from various facilities revealed that the majority felt unprepared to interact with patients with ID and/or autism. This mainly results from insufficient educational preparing during their studies and gaps in professional training. The healthcare environment is often unsupportive. Excessive stimuli, noise, lack of visual aids, strict procedures, and time pressure cause individuals with ID to feel lost and unable to fully communicate with healthcare providers. The study identified a phenomenon called the riding on the health environment. The physical condition of medical facilities are too inflexible to allow any adjustments to meet the individual needs of patients. Moreover, people with ID are often not directly involved in conversation, as healthcare staff tend to communicate with their caregivers instead. This can lead to a patient being overlooked and diminish the quality of information. People with intellectual disability often face attitudinal barriers in healthcare, including stereotypes that undermine their dignity and competence. Healthcare staff, especially nurses, may feel anxious about communicating with them, fearing mistake or causing them. As a result, they often avoid direct interaction and speak mainly through caregivers, which increases patient fears or marginalization. Infantilization is common with patients treated like children through simplified language and patronizing tones, denying them equal partnership in care. Studies show this leads to dehumanization and lack of respect. Stigmatization and social distance also occur as healthcare providers often feel uncomfortable and unprepared to communication effectively, sometimes avoiding full engagement. These attitudes reference harmful views that people with intellectual disabilities are less compelled, leading to ignored needs and patient avoiding seeking help. Modern cancer prevention, increased linking, use digital tools, online campaigns, appointment booking, and reminder system. However, people with intellectual disabilities often face barriers with this technology, making it hard to access screenings like mammographies or colonoscopies. Key obstacles include complex website and registration apps with difficult forms, medical jargon, and multi-step verification like email or SMS codes. Many with intellectual disabilities don't understand the purpose of screening or how to book them, even with caregiver help. This is also a lack of easy to read educational materials or alternative communication formats. Public campaigns rarely target this group, so they often miss cancer risk screening needs and warning signs. On common issue in health care for people with intellectual disabilities is the lack of innovation and information about screening tests like pap smears, mammographs, or colonoscopies. Medical staff may assume the patient won't understand or won't cooperate or isn't sexually active, leading to their exclusion for preventive programs. This violates the principles of equal treatment and denies them their right to healthcare. Another major concern is communication that bypasses the patient, entirely focusing only on their caregiver. Yet effective tools exist such as facilitated communication, in short FC, where a facilitator supports the person in expressing themselves by pointing to letters, symbols, or using a keyboard. FC enable non-verbal individuals or those with speech difficulties to communicate their needs, fears, and health-related questions. Dismissing such tools renders patient invisible, raising the risk of misdiagnosis and neglected symptoms. In preventive healthcare for people with intellectual disabilities, understanding the concept of double empathy is essential. This idea originally proposed by Douglas Beacon in the context of autism, highlights the communication difficulties arise not only from the individual's challenges, but also from the environment's lack of readiness to understand their unique way of thinking and expression themselves. People with intellectual disabilities may interpret medical information differently, express emotion in unique ways, and respond to stress during explanation in ways that can be misunderstood and resistance or not cooperation. Double empathy calls for mutual effort. Healthcare providers must simplify communication, listen, anti-value, and respond to both verbal and nonverbal causes. In cancer prevention, neglecting this principle can lead to refuse of screening due to unrecognized anxiety. On the other hand, a patient-centered approach using clear examination, visual aids, and patients can reduce fear and boost trust. The lack of effective communication of people with intellectual disabilities has serious health consequences, particularly in cancer prevention. The participate lost often in screening tests such as mammography, pap smears, or colonoscopy not because they are a lower risk, but because they may not understand the purpose of the procedure or haven't had it explained in an accessible way. As a result, cancer are often diagnosed later at more advanced stages. Studies show that breast cancer in women with intellectual disabilities is diagnosed later and treated less aggressively, leading to worse outcomes and higher mortality. Delays in treatment are also more common due to issues with consent or environments not adapted to their communication needs. In summary, communication environment, fundamental and systematic barriers significantly hinder people with intellectual disabilities from assessing cancer prevention. Difficulties in communication, lack of adequately trained staff, and adapted medical environmental result is many patients being excluded from opportunities for regular screening early diagnosis detection. Additionally, stereotypes and infantilization lead to marginalization of these individuals, while complicated procedure of the absence of tailored materials deepen their isolation. To improve the situation, it is essential to implement staff training, simplify communication, introduce methods to support interaction, and foster more empathic and partnership-based attitudes. This is the only way can we assure equality access to healthcare and greatly improve the quality of life for people with intellectual disability. Thank you very much.
Okay, thank you too. Monika, for your compelling presentation. You've brought important attention to the communication barriers that individuals with intellectual disabilities face in cancer prevention. Your exploration of both the challenges and practical solutions offer a vital step toward more inclusive and effective healthcare communication. And now I'm inviting Genevieve Breau. Sorry if I don't pronounce your surname correctly. Working together to make a video about bowel screening, an inclusive research approach to video co-production. This work emphasizes the importance of co-production in healthcare education, ensuring that individuals with intellectual disabilities are actively involved in shaping resources that directly impact their health. Genevieve, please put your presentation on full screen mode and start.
Great, thank you for the introduction. So it should be on full screen now. So today I'm Dr. Genevieve Breau, and I'm presenting on working together to make a video about bowel checks. Just a note, I'm going to be presenting using more accessible English because this was an inclusive research project. When I first did this presentation at a different conference, there were people with lived experience in attendance, so this was to accommodate them. So working together in a group. So for the past 2 years, I've worked with Bexley MunCap, which is a charity in Bexley Heath in London, UK. So this is a group of people with learning disabilities who advocate for themselves. So we've met several times over the past 2 years to talk about their ideas about how people with learning disabilities can be healthier. So we decided to make a video. So some group members suggested making a video together about the need for bowel screening. So the reasons we decided to make a video is because not everyone who needs a bowel screening kit does this. So there are many reasons why someone wouldn't do a bowel screening kit. So in the UK, people in the eligible age range get a bowel kit in the post. So fewer people with learning disabilities do this kit. It may be because they think the kit is icky. It might be because they don't understand it's a bowel kit or how to do it. Or it could be they're nervous that if they do the bowel screening kit and it's a positive result, that they might need more tests at the hospital, and this can be scary. So in May and June of last year, in 2024, we meant to talk about what would go in the video on bowel screening. So we had a series of 3 meetings. Once we agreed what would go in the video, we met in July 2024 to film the video, and we finished the video in July last year. So what I'm gonna do, I'll see if it works. The video we made is only 3 minutes long. So what I'm gonna do is share the video and just play it now. So I think you can see the video now. So I'm just going to share it. What is bowel screening?
Is to check your poo. Is to check for blood in your poo. Is to make sure you don't have cancer.
Most people don't have cancer, but it's still good to check. The bowel is where the poo is made in your body.
Why is it important?
To make sure you are healthy.
It's good to check.
Can you ask for help with bowel screening?
Don't be scared to tell someone. It is important to tell somebody.
Who can you talk to?
Carers and supporting workers, family members, friends, staff at your GP surgery.
Who can you talk to?
Someone you know and trust.
Someone who is cared.
So, poo is basically the rubbish that your body makes. So when you eat food, whenever your body doesn't want, it turns it into poo. So when you eat food, you chew it in your mouth, then it goes down a tube called your esophagus to your stomach. Then the body takes what it wants in your stomach and your intestines, and then it sends the rest to your bowel to make poo. Sometimes people can get a bump in the lining of their bowel, and when the poo passes by, a little bit of blood can get into the poo. That's what the bowel kit does. It checks for little bits of blood in your poo. Now, most people who do the bowel kit don't have cancer, and even if the doctor wants to do follow-up tests, most people don't have cancer. However, it is good to check just to make sure everything's all right.
Five and get it done.
Talk about it and get it done.
Be positive about it.
You can do this.
You can do this.
You can do it.
Yeah.
Yes, so that was the video we made. I'm just going to reshare my slides. I only have one left. There we go. So let me see it. So what we learned about making the video. So making the video was a bit hard, but both me and the self-advocates I worked with learned a lot. So we want to share this video to encourage other people to get bowel screening. And in the future, we would like to make more videos about different health topics. So we are currently working, we're quite far along making a video about what doctors should know treating people with learning disabilities. We've also made a start on doing 2 videos, one about breast screening or breast self-checks in women with learning disabilities, another about testicular cancer self-checks, people with learning disabilities. So just to conclude, I'd like to thank the members of the Friday Respect Group at Bexley MunCap. I'd like to thank, so some of the self-advocates you saw in the video, but everyone in attendance helped develop the video. I'd like to thank Jane Menzies and Steve Grimsey, who are staff at Bexley MunCap, Sarah Hadou, the research assistant who edited the video, and the University of Greenwich, who gave funds to create the video through their early career academic pilot project funding scheme. So thank you very much. I'll stop sharing now.
Yes, Genevieve's presentation offered a powerful example of how inclusive research can lead to more effective and meaningful health communication by actively involving individuals with intellectual disabilities in co-production of educational materials. You saw the videos. And this project not only fosters greater engagement, but also ensures that the final product truly reflects the needs and voices of its audience. It's a strong model for collaborative and respectful, healthcare communication. And now we are going on the last presentation. Unfortunately, Natalie Gil from UK is not with us. She is on annual leave, but she sent me the video presentation. The title of her presentation is Cancer Risk Factor and Symptom Awareness Among People with Learning Disabilities, Paid and Unpaid Carriers and Healthcare Practitioners. Raising awareness among all stakeholders, including carriers and healthcare professionals, is crucial for early intervention and improve outcomes. Now, let me to start her presentation. I hope that it will go smoothly. It is on PowerPoint with video, and I will start it.
Hello everyone, and welcome to this presentation.
I'm not sure. Yes, it should be. Here, I don't know the screen.
Hello everyone, and welcome to this presentation.
Can you see it?
My name is Natalie Gil, and I'm a postgraduate researcher in health sciences at the University of Surrey in the UK.
Do you hear the voice and do you see the screen? Okay, thank you, Margaret. We'll go on with this presentation.
So for those of you who don't know me, I'll give a very brief introduction to myself and my research. I'm a psychologist by background, and I hold a bachelor's degree in applied psychology and a master's degree in health psychology from University College London, which is where I began in the field of cancer research. After graduation, I was then employed as a researcher in the Department of Behavioural Science and Health at UCL, where my work focused on inequalities in cancer screening. I moved to the University of Surrey
Hi, Vladimir. We don't seem to have any sound, so we can't hear Natalie's speaking.
I'm sorry. That's why I asked you on the beginning. Do you hear the voice? And but Margaret confirmed me. Okay. I will try now to
But
solve.
I just heard it briefly, Vladimir, and then it went.
I don't know what's the. Okay, I will try now. Please tell me, is it okay?
Therefore, the awareness of risk factors and symptoms is increasingly relevant for early diagnosis of cancer for people with intellectual disability. However, we know that people with ID have low levels of health literacy, and there's a lack of tailored public health messaging around cancer prevention. People with ID also experience significant disparities in accessing all aspects of healthcare due to direct and indirect discrimination, lack of support, and difficulty in navigating complex healthcare systems. To date, little appears to be known about cancer awareness among people with intellectual disability and their support network, and there has been no review synthesizing the available evidence on the topic to guide and understand. Therefore, the aims of this review were to provide an overview of what is currently known about risk factor and symptom awareness for people with intellectual disabilities, paid and unpaid carers, and specialist and non-specialist intellectual disability healthcare practitioners, to build an accessible database of scientific papers that explore awareness of cancer risk factors and symptoms, and observe and document current and historic research trends, to identify gaps in the knowledge and determine areas for future research. So for this scoping review, I followed the Arksy and O'Malley definitive framework for scoping reviews, which follows 5 incremental stages. Stage 1 is identifying the research question and defining the parameters of this. Stage 2 is identifying relevant studies, which includes choosing and searching electronic databases. Stage 3 is study selection, applying a predetermined inclusion and exclusion criteria. Stage 4 is charting the data. So this step is where we extract data, usually using a data extraction framework, and synthesize and interpret aspects of the data. Finally, stage 5 is where the data is collated, summarized and reported, and an overview of the studies that have been reviewed is provided, including the extent, nature and distribution of the research. Okay, so let's look at the results from this review. There were 352 records identified, 45 duplicates removed, 25 retrieved for full text review, and 16 papers for final inclusion. The majority of research was conducted in the UK and Ireland, with some studies from the US. 8 studies were quantitative, 5 qualitative, there were 2 reviews and 1 project report. The cancers of focus were breast, general cancer, breast and cervical, bowel and testicular, and the population groups being studied were adults with intellectual disabilities, carers, advocates, nurses, and other non-specialist healthcare practitioners. Based on the data I extracted, I formed a narrative synthesis, and this involves a detailed textual analysis where themes and patterns are identified between papers before findings are integrated in narrative form, where similarities, differences, and gaps in the literature are explored. I developed 2 overarching themes of risk factor and symptom awareness and interventions to improve awareness. There were 5 sub-themes sitting beneath those. So for risk factor and symptom awareness, these were breast cancer awareness among healthcare practitioners and paid and unpaid carers, breast cancer awareness among people with intellectual disabilities, and awareness of other cancers. For the theme of interventions to improve cancer awareness, the sub-themes were breast cancer interventions and interventions for other cancers. The findings from the review were perhaps unsurprising in that cancer risk factor and symptom awareness was low among people with intellectual disabilities, but actually across all the population groups included in the research. And when there is an awareness, adults with intellectual disabilities often display a fatalistic view of cancer. Carers of people with intellectual disability appeared to have no greater cancer knowledge than the general population, despite being tasked with the responsibility of their day-to-day healthcare. And there is also a lack of risk factor and symptom awareness training for intellectual disability staff and family carers. Breast cancer research predominates in this area, Also, when adapted measures were used to capture awareness among people with intellectual disabilities, it was not clear how accessible these measures truly were. There was a persistent lack of theoretically underpinned or co-designed research. The conclusions drawn from the review were that there is a great deal of uncertainty around how to raise cancer awareness for people with intellectual disabilities among carers and also other healthcare professionals. There is also uncertainty of where the responsibility lies to facilitate this knowledge. There needs to be a consensus on how to facilitate and empower people with intellectual disabilities, where possible, to participate in their own healthcare. And further research is needed, particularly across multiple cancer types and across cancers which may be more common among people with intellectual disabilities, in order to build a complete picture of awareness. Finally, the review was submitted for peer review to the Journal of Intellectual Disability Research and was published in 2023. Next steps. So following on from the publication of this review, I have now conducted a qualitative study exploring the lived experiences of the pathway to diagnosis with both people with intellectual disabilities and advocates working in the roles that support people with ID to access health and/or cancer care. The aim of this research is to gain a deeper understanding of how this process unfolds for people with intellectual disabilities, including their awareness of symptoms, experiences of help-seeking screening, and their interactions with healthcare. I'm currently in the analysis phase of this project and hope to have this submitted for publication this year. I'd like to thank CUPID for the invitation to share my research with you all today and acknowledge the ongoing support from my supervisory team, Dr. Rob Kerrison, Dr. Anna Cox, and Professor Katrina Whitaker, as well as my clinical supervisor, Dr. Emily McBride.
Okay, thanks to Natalie Gil for sending us this video. I'm sorry for the first 3 minutes. I was not aware. I couldn't open chat. I saw that there are some messages, but I couldn't because it will appear on the screen. So, I heard the voice on my computer, but you didn't hear the voice. You don't hear the voice. This video will be uploaded on the CUPID YouTube channel. Now, I'm opening the Q&A session. You're welcome to put your questions in live with your camera and your microphone. And also, if you don't want that, you can send us your questions in the chat box. So, who wants to start? Dr. Margaret Denis raised her hand, please.
I mean, very interesting. All of the presentations were excellent, and I learned so much. For Amina, I was just wondering, it's interesting that the age profile for mammography is 50 to 75. And the other thing I was wondering in terms of Amina was the experiences and attitudes of and the perceptions of healthcare professionals. It's so hard to measure in terms of attitude. So you get a view in principle and a view in fact. So I was just saying, just consider that as well in your research. That's Amina. Will I go down through all my comments, Vladimir?
Yes, please.
And then I thought Anna DeWitt, I was just wondering, isn't it an amazing intervention in terms of gamers? And I'm just wondering, had she considered, Vygotskian theory in terms of the zones of proximal development, how kids learn from one another, which is huge in terms of gaming, and another way to learn. So that's just a comment, but excellent. Monika, I think facilitated communication seems to be the way forward, and we need to do that far more in research with persons with intellectual and developmental disabilities. For Genevieve, I thought the video presentation was absolutely excellent, very well made, and truly got across the point. And the code design was just brilliant. Yeah, well done to you. And then finally, Natalie, I'm interested because, of course, we're just completing our scoping review and she's using the same framework. And I'm interested in her second paper. Excellent presentations, I have to say. That's all I have to say. Thank you all. It was excellent.
Yeah, thank you, Margaret, for this short overview of all presentation. You, as experienced researcher and scientist, make a very good, very nice overview. So now I'm asking the other people from the audience. We have 32 participants at the moment. Even we have 66 registered participants on Google form, but some people are busy or some people, I don't know, forget. Even I sent yesterday because I want people to forget, and that's why I sent you the Zoom link yesterday evening. Okay, we are going. I can't see the questions or remarks, comments in the chat room. Are there any other comments from the speakers or from the other people from the audience? I saw a lot of names from CUPID members, and also I saw some names which are my younger colleagues from Macedonia, and I thank all of you for your presentation. Okay, if there is no other questions by the audience, I will close this webinar with few sentences. A study on cancer prevalence in individuals with profound and multiple disabilities found that while overall cancer risk may be lower due to shorter life expectancy, certain cancers, particularly digestive tract cancers, occur more frequently and at younger ages in this population. And this study reinforced the urgent need for improved cancer screening, diagnosis, and treatment strategies tailored to individuals with IDD. As Margaret said, we have a very fruitful and very respectful 5 presentations today. I, as a WG4 leader, I am very satisfied with today's webinar. I can say that it was successful. We are for more than 1 hour together today, and I want to finish this webinar with announcing the annual conference of all WG groups on 6th of October. In between, we CUPID members, we will have some another meetings in September in Amsterdam with early career researchers, which will lead by Kate, Margaret, Suzanne, and Vera. Also, we will have some another activities. Other working groups. Working group 4 will follow all activities and will share on our social media. I already put the links in the chat room. So thank you very much for attending on this excellent webinar and for your thoughts, for your sharing your experiences, especially for the speakers. And take care of your health, and I hope to see you at the end of the summer or beginning of the autumn, some of you in Amsterdam, and for the other on the annual CUPID conference, as I mentioned, on the 6th of October. So I wish you a good day and have a nice summer from 20 1st of June. Okay, even now in Skopje, Macedonia is summer with 34, 35 degrees those days. Okay. Bye-bye. Thank you for your attention.
Thanks,
Thank you.
Vladimir.
Bye, Kate.
Bye-bye. Vladimir, I'll be in contact in July.
Yeah, thank you very much. I'm waiting for your contacts
Yeah,
and for your...
early July, I'll send a Zoom. Okay, thank you.
Yeah, we'll be in touch in Zoom.
Okay.
Okay.
Thank you.
Thank you all.
Bye-bye.
Could you hear me, Somer hocam?
Bir bilgi hocam.
Hayır.
Toplantı bitmiş. Toplantı
Aa,
11'deymiş.
hadi ya. Üzgünüm ya.
Toplantısı 10 a.m. Central European'miş, bir saat fark. Not 2 hours. One hour difference.
Neyse o zaman görüşürüz. Boşa.
Görüşürüz.
Ben de deminden beri ses ayarlamaya çalışıyorum burada.
Ben de dedim ki
Ben
internet
duyamıyorum.
çalışmıyor diye.
Ben,
Neyse.
ben duyamıyorum zannediyorum. Tamam.
Alright.
Görüşürüz.
Çorba ısmarlayabilirim.
Olur hadi gidelim. Gel.
Gidelim. Hadi bay bay.
Assumption.